Here we go. We're rolling. If
All
y'all want.
right. If you could first of all say and spell your first and last name for us.
Okay, I'm Greg Marchand. Greg is Greg, and Marchand is Marchand.
Okay. And what would you like us to put as what you do? It's the line that goes underneath your name.
Um, uh, Probably gynecologic surgeon.
Okay. Okay. First, you can just look at me. Tell me about this procedure that you pioneered, the in-bag morcellation.
All right. Well, after doing hundreds of cases laparoscopically of taking out tumors that I thought were benign, I realized I had to develop a technique to treat even larger tumors. And after about 2014, the FDA put out that black box warning, uh, basically saying that morcellators weren't very safe unless it was done in a contained environment. So I developed an in-bag morcellation technique that I would use on these large tumors. Because trying to be a responsible surgeon, the options were either to develop an in-bag morcellation technique where I could contain all the parts of the tumor, or to cut the patient wide open. And I really thought that wasn't the best thing for my patients, to cut them wide open. So over the course of doing hundreds of cases laparoscopically, I developed this technique that's a little different than other in-bag morcellation techniques. My technique relies on bringing the mass up to the instruments as opposed to going after it with the instruments, and using just blunt instruments to make sure you don't rupture the bag in any way.
So morcellation would be cutting up the tumor inside the body and then pulling them out.
Right.
The in-bag part is the part that you pioneered.
Right, I pioneered a special in-bag morcellation technique that can be used on very large masses. Previously, and on tumors that you suspected to be benign, it was more acceptable to do a morcellation that wasn't contained. But in 2014, the FDA put a black box warning out, essentially saying that that wasn't the highest level of care because of the possibility of spreading an unexpected cancer throughout the abdominal cavity.
What's the bag made out of?
Well, there's different kinds of plastic. A lot of bags have a lot of strength to them, but one of the weaknesses that almost all bags have is the incidence of sharp instrument contact. A sharp instrument or an electric form of energy will often rupture the bag.
So you use, is it scissors? Is it a scalpel with a blunt edge? What is it that you use?
Well, I tried several different things, but ring forceps and placenta forceps seem to do the best job. They really get a good grip of tumor tissue, and because they have rounded edges, that they're not really at risk of cutting the edges of the bag, as long as you're keeping the bag good and taut during the technique.
So walk us through the actual procedure. What are you doing from start to finish?
Well, if we're talking about just the technique, well then first we're going to isolate the tumor in the abdominal cavity without rupturing it. Okay, so that's going to mean dividing it from its ligaments. Since it's usually an ovary we're talking about, you've got to cut off the suspensory ligament of the ovary, as well as the infundibular pelvic ligament and the ovarian artery. Now after that, you've got the mass free in the abdominal cavity. So at that point, you need to get some washings of the inside of the abdomen to be sure that there hasn't already been the spread of cancer throughout the abdomen. The next step after that is going to be to carefully encapsulate the mass within a plastic bag, and then the all-important part, to exteriorize the mouth of the bag. And then once you've got the mouth of the bag outside the patient, that's when my technique really goes to work, to take it out piece by piece until you've got the entire mass out of a very small hole.
And then what is the oncology portion of it when we were talking about cancer?
Well, as a gynecologic surgeon, I often work hand in hand with gynecologic oncologists. Now, gynecologic oncology is a subspecialty of OBGYN where they've done extra training to complete a full staging procedure for ovarian cancer. So while I'm proud of my technique, and it certainly can be used to safely remove large cancerous tumors, I do rely on a gynecologic oncologist to be present and to finish the complete staging procedure.
So they can stage. What's the advantage of staging during the surgery?
Well, you would save the patient from having a second procedure, because for most ovarian cancers, really the first step is staging the cancer to find out what stage it's at, and that determines future procedures or future treatment.
So that would be traditionally a biopsy. Or am I on the wrong track here?
You're on the right track, but with ovarian cancer, it's not really a biopsy because you don't want to break the capsule and spread the cancer. So biopsy, unlike a breast tumor, is not really on the table.
Okay.
So you need to do a full surgery to find out the stage of the cancer, and that's going to entail both using it could entail using my technique to remove a large tumor, but it also requires other surgical procedures to be done to realize the stage of the procedure.
So for ovarian cancer, the staging is part of the removal of the tumor.
Right.
Because there's no biopsy, because it's not safe.
Right, ovarian cancer is staged surgically, meaning you really have to do a staging procedure or surgery in order to get the stage of the procedure. And I'm sorry, get the stage of the cancer. And that's where my procedure really works quite well if you can do it at the same time as an ovarian cancer surgery. I'm sorry, as an ovarian cancer staging surgery. As you know, I've been able to combine this on occasion with a gynecologic oncologist to do an ovarian cancer staging procedure. And then it's really quite wonderful for the patient that you can complete the whole procedure through tiny holes.
And have all the answers right then.
Absolutely.
Okay. How many procedures do you think you've done? Well, first of all, you wouldn't have the oncologist there unless you already knew it was cancer, right?
Well,
or is it just you suspect that it's cancer?
On any mass where there's any reasonable suspicion of it being a cancer, I'd want to know what the diagnosis was before I left the operating room, and I'd want to have a gynecologic oncologist, if not right there in the room with me, available on call to come in right away.
So they don't necessarily with you at the beginning of the surgery, but you can call them in during the surgery.
Right, in many procedures, we do what's called a frozen section. That's where after I remove the tumor, send the tumor to the pathologist, who then gives me an immediate diagnosis. It's kind of a special way to do pathology where they give you a quicker answer, and then with that answer we can either go forward with the cancer staging procedure, or if it's simply a benign tumor, the procedure's done, we could just close up.
Okay, so this is done while the patient's still in the operating room.
And still asleep.
What kind of results have you seen so far?
Well, thankfully the majority of the masses I've performed my technique on have been benign. So I've had wonderful results with patients who had very large tumors, in excess of 10 centimeters, going home with only small holes and often leaving the hospital the same day. So it's really rewarding to see the patients have such a quick outcome.
How many years or how many patients or both have you used this procedure on? Any way to tell?
I'd estimate somewhere in the range of 700 to 900, because I started at one of the larger hospitals here doing the majority of the emergency gynecologic surgery, and my case count is somewhere in the range of 1,800, and then you figure about half of that is vaginal surgery, so counting about the laparoscopic portion, about 700 to 900, I would say, actual.
And how many years? Over how many years?
Since 2009 I came out here, so it's 8 years now.
Okay. So would you consider this still a medical breakthrough or more of a general medical story, just an alternative for people facing this procedure?
Well, so as far as using my technique, I think my technique's a very good technique for performing in-bag morcellation, but it's not the only technique. I mean, where this technique really becomes exciting is when we find a cancerous tumor and then we combine removal of a very large cancerous tumor with a complete ovarian staging procedure. So then you've got a patient that came in, unfortunately, has the diagnosis of cancer, and then instead of being put through 2 surgeries, or instead of being put through a large open surgery, they can wake up and they're essentially able to go home that same day. And I mean, that's going to be a lot less recovery and a lot less pain for the patient. And a recent study just came out of Milan, the Cancer Institute there in Italy, that compared 3,000 cases of ovarian cancer that was staged. 1,500 of them, they randomized them to be staged laparoscopically, and 1,500 were staged through a large open incision. And they really found that in the laparoscopic cases, the patients recovered more quickly. They were actually able to start chemotherapy a lot more quickly, and they were able to get back in their lives more quickly. So it's really a great benefit to somebody that's just been diagnosed.
Let's talk about the 17 centimeter tumor. Just tell me a little bit about that, how you treated that one.
Right. So, like any other case, I was aiming to be as careful as possible. So I took the patient in the operating room, and like all my patients, I consented them that I didn't think it was going to be a cancer, but there was a possibility. And then I went forward, and there was a 17 centimeter tumor. And luckily, thanks to the shape of the tumor, we were able to place the tumor inside a plastic bag safely, and then safely exteriorize the mouth of the bag. From there, I was able to use my laparoscopic technique, using my technique of in-bag morcellation to remove the tumor piece by piece through the tiny incision. And unfortunately, the diagnosis then came back as a cancer when we got the frozen section, and the gynecologic oncologist that I was working with at that time was nice enough to come right down, and it was really quite fantastic that he was able to complete the entire staging procedure. Now, in cancer, we don't ever say that something is cured until, well after the certain amount of time you have to wait to be sure the cancer is not going to return. But in a case like that, a patient may have gotten a cure on essentially an outpatient basis with an extremely minimally invasive procedure. And that really has to mean quite a lot. When I had my procedure for testicular cancer, I was very fortunate that I had a good surgeon and that the technique for testicular cancer is already very minimally invasive. So when I woke up from that procedure, I really felt strong. I felt ready to fight the cancer. And I really hope that that's the feeling I give my patients after these minimally invasive surgeries, because I can imagine when you get one of those very large up and down midline incisions, you wake up in bed feeling like you've been hit by a train. I mean, you're really hurt, you can't move, and it's tough to, I imagine it must be very tough for my patients in that situation to feel like they have the strength to fight the cancer. I mean, it probably feels like a lot more like giving up. Yeah. And I think that's the worst thing a patient could have to feel after getting a diagnosis like cancer.
So as a physician who has been through the experience, it seems like, I don't want to put words in your mouth, but your relationship with your patients who have cancer has to be a little bit different.
Absolutely. Yeah, I mean, obviously the most terrifying thing in my life was the cancerous diagnosis, and I'm very grateful to the surgeon that I saw. It was in 2010. I was diagnosed with mixed cell testicular cancer. I'm very fortunate to have had a good surgeon, and the technique she used was minimally invasive, and I recovered very quickly, and that's part of the impetus for me to develop these techniques is to want to share that feeling of, I had surgery, but I have my strength. I feel like myself. I feel like I can get back into my life. I feel ready to fight the cancer.
Perfect. What haven't I asked you that you think is important to get in the story?
What about why I sought the world record?
Sure.
Yeah. So after we did this procedure, it was pretty remarkable, and I had discussed it with the gynecologic oncologist who also thought it was remarkable. I was talking with some of my colleagues about it, and they really thought it was a remarkable thing to have done an ovarian cancer staging procedure laparoscopically on a 17-centimeter tumor. So as a result, one of them actually said, Greg, that's got to be some kind of record. So we joked about it a little, and when I got back to the office, I talked about it with my office staff, and I'm blessed to have a really wonderful clinical staff here. And sure enough, they actually looked into it, and it was a record. They did the necessary paperwork, and then the next thing I know, that the record, actually a record certificate was awarded. So I'm really grateful for my staff, and I really hope that this world record really can bring attention to minimally invasive surgery.
It wasn't Guinness, it was a different accrediting agency, wasn't
it? Right. When my staff was looking into it, I don't know if you can see, I've got a Guinness certificate on the left from a procedure I did a few years ago with another surgeon. They originally sought to have it approved by Guinness, but Guinness said it was a little too specific, that it was both the largest ovarian tumor that was staged laparoscopically, so they said it was a little too specific to use. So my wonderful staff here went ahead and checked, and there were a lot of surgeons using the World Record Academy to recognize their records.
Okay.
And sure enough, after we verified that it was the largest and they verified it was the largest, they awarded the certificate.
Cool. Then I can look that up online probably.
Absolutely.
Okay. Great. Let's put you across the hall.
Okay.
And
Real time. Go ahead and just do your stuff. Just talk about it.
All right. Well.
But you don't even have to be there.
Oh, don't be there. I'm sorry. All right. Well, picture on the left is a midline laparotomy incision that would be the incision often used for performing an ovarian cancer surgery on a patient with a large tumor. In this case, we're talking about a 17-centimeter tumor. And as you can see on the right, because this procedure was done laparoscopically through a very small umbilical port, we were able to do an in-bag morcellation procedure to remove the mass, thus leaving the patient with essentially no scar. If you look at that belly button, that's what they call an outie. We've hidden the scar on the left side of the incision where it's really not visible. That, and using small 5-millimeter incisions below the pubic hairline, completely hides all the evidence of the procedure.
Scar's like a centipede.
that's a big ugly scar.
Well, hopefully she was cured of the cancer.
It's actually kind of like a war wound.
Mm-hmm.
I mean, yeah.
Yeah. If those were too graphic, I had drawn it on at models here.
too graphic for Marjorie.
All right. Yeah.
Yeah, so you didn't clear now, we're in focus. Okay, we are rolling, go ahead.
Okay, what are we looking at here, Doc?
Well, as you can see on the model on the right, I've gone ahead and drawn the incision that you would usually have for an ovarian cancer staging procedure. You got a very large 19 centimeter incision. It's a midline vertical laparotomy that goes around the belly button. And that's really what you need to remove, you need an incision at least of this size to remove a 17 centimeter tumor.
Okay.
And using my technique in comparison and using this retrieval bag, we were able to make just a very, very tiny 1.2 centimeter incision in the umbilicus, which we were then able to stretch around this device, which is about 1.5 centimeters in total diameter, or a little bit smaller than a dime. And then after we get this device inside the abdominal cavity, that's when we can go ahead and deploy the bag and then scoop up the mass.
Okay, stand by. Got it there. Go ahead and point at that the big incision. Yeah, same way you did before. Start at the top down, come on down. Okay, great. And now we're going to go over to the belly button.
Mm-hmm.
Same routine there. Just show us what that looks like. Okay, stand by here. Make sure that's in focus. Go ahead and put that stick back up there. Sorry. Sort of focus on that fleshy belly button. I can't see.
Oh, it's the color.
Yeah. Okay, one more time. Just kind of do that one more time for me. Okay, and now show me the diameter of that thing. Just point at the camera like you did
The
before.
diameter of the
dime?
yeah.
Mhm. So see that real quick.
Mm-hmm.
Okay, memorize where your hands are right there. Memorize that and bring it up to that point. Try that, okay? Drop it down and bring it up to that point. Bring it on up. Good. We'll drop one more time to say we did. Drop it down and up. Great.
So,
stand
do you
by
want to go
there.
side? Well, I'll let you decide.
Yeah, I'm good for right here.
Okay, but
And don't look at me.
Okay.
And you can once you pick it up from where you're talking about the diameter, talk about that diameter again to her for a minute.
Okay.
And then just go. Okay.
So we stretched the 1.2 centimeter incision without a port to go ahead and fit the 1.5 centimeter instrument here. So we're talking about a really small hole, smaller than the size of a dime in diameter. And then of course, once we have the tip of this instrument in there, that's when we'll deploy the very large bag, and then we can scoop up the mass, and then by exteriorizing the mouth of the bag, we can take it out piece by piece safely without worrying about spilling it back into the patient's abdomen. So if we can pretend the tip of this is in the patient now, I'll go ahead and deploy the bag, and I'll show you what that looks like. This is the bag we'd use to scoop up the mass. And you can see it's quite a large bag. You could use it to pick up a mass. It's actually 23 centimeters in depth, so we were able to remove a 17 centimeter tumor with it. You could remove quite some large tumors.
Great. Is that
do it once.
Right. Per bag, we got 2 bags.
Gotcha.
okay? And just go ahead and talk us through that thing.
Oh,
Okay?
what are you doing?
So here we've got a representation of a tumor in the bag. There aren't actually no watermelon tumors, thankfully. But then once you have the tumor or the mass within the bag, you can go ahead and close the mouth of the bag and then seal the tumor in, and it actually sews it shut. And that's the next step before you exteriorize the mouth of the bag. And then you pull that through, and you end up with the mouth of the bag outside the patient, giving you a nice plane to attack the tumor with without fear of spilling the tumor.
So you close it like that before you start cutting it up.
Right. I would bring this mouth of the bag outside the patient, and then that would then be my field of working through this very small incision to take out the tumor mass piece by piece.
Okay.
Since this mouth of the bag is exteriorized or outside the patient, there's really no danger of this tumor mass getting around and falling back in.
Okay. Okay. And then you show us the instruments that you use.
Okay, now we're gonna do a little peekaboo with that tumor, right?
Yep.
Where you're gonna kind of reveal it, and go ahead.
Yep, so once I've got the mouth of the bag outside the abdominal cavity, I can pull the edges taut, and that'll give me this area right there that I could attack the tumor. I could start taking out piece by piece without fear of it dripping back in the abdomen, because I'll pull this very tight outside the patient.
Great.
All right.
Yeah, do you understand where he is?
Should I be looking at you or looking at her?
And we are rolling.
Okay, and then once you've got the tumor in the bag and the mouth of the bag is exteriorized or outside the patient, my specific in-bag morcellation technique is to take large coker clamps and place them on the sides of the bag, such as this, And then that gives you the ability, after you've got a few of these on there, to twist the coker clamps, and then that keeps the bag constantly taut against the skin. By keeping these bag edges taut, there's no possibility of fluid or cancerous cells leaking back into the patient. At this point, when you've got it taut against the patient's abdomen like that, I then use only blunt, curved instruments to remove the tumor piece by piece. Now, I'm not going to be able to take this tumor apart piece by piece, but normally this would be the process to remove the tumor until the entire tumor mass is out. This could take quite a bit of time if it was a very large tumor.
Like when you say quite a bit of time, an hour, 2 hours, yeah?
Yeah, the longest I've had it has been an hour and a half for a very large tumor.
Okay.
And does it like, just for my own information, is it like peel off? You're ripping it apart, or?
Well, it depends
Because
what.
it's dull, right?
Depends what kind of tumor. You know, the cystic tumors, like you said, can peel apart. As you grab one cystic area, it'll tear away from the rest. Solid tumors can be more difficult. It can be like tearing apart a hard steak or you know, a hard piece of meat where it really doesn't want to come apart piece by piece, in which case you'll have to twist and maybe use some different instruments.
But nothing sharp.
Right, nothing sharp. The last thing I want to do is break this bag and spill cancerous material back into the patient's abdomen. Yep.